Hi, this is Ike Ahmed from the University of Toronto. I practice in the Toronto area. My practice is primarily cataract, intraocular lens, glaucoma, and anterior segment repair. When it comes to modern day IOL calculations, it's pretty apparent to me that both optical biometry and keratometry is critical. And in fact, for most of our patients, we use topography routinely. And it's not just about IOL calculations, it's also about assessing the corneal shape, it's about assessing for other corneal abnormalities, and certainly is an essential tool for toric IOLs. This usually requires multiple measurements over multiple machines. The ability to combine, of course, topography with an optical biometry or keratometer is of immense value as far as workflow and having everything all in one platform, having a printout that can give you all information about the cornea, about the corneal aberrations, about corneal topography, and of course the essential optical axial length as well. So we find the form factor and the workflow with this device to be essential and very helpful in a busy cataract practice. We use corneal topography and along with that pupillometry routinely in premium IOLs, and there are many reasons why. Obviously measuring the cornea is important to look for any irregularities. Look for form fruct keratoconus, look for irregular cylinder, look for any abnormal corneal maps. This may give us an indication this patient may not be a great candidate, for example, for presbyopic lens, or in fact will give us a reason to talk to the patient about perhaps expectations may not be exactly 20/20 for some patients. We of course use it essentially for toric lenses, very important for looking at the axis of cylinder for correction. And then pupillometry also is becoming more important for a few reasons. One of the reasons is, of course, looking at the concern as far as aberrations. Patients who have larger pupils, we pay more attention to spherical aberration, which we of course measure on topography as well. Looking at certain multifocal lenses, important to assess maybe a patient's risk or a patient's performance based on the way that the multifocality is developed as well. And thinking about visual axis as well. Thinking about visual axis and centration of lenses, angle kappa and the sort are all important variables in terms of looking at the pupil, looking at the visual axis, looking at the cornea as well. So I like to get a real complete picture of the anterior segment and the visual axis. Unfortunately with keratometry alone, that doesn't give us enough information. And the entire picture, including corneal topography, is really, I think, the ultimate in terms of IOL selection and patient selection for that matter. One of the most annoying things that I do routinely, and our staff do routinely, is entering measurements manually on the website, calculator, or another software. Errors happen, workflow issues occur. So we love, of course, when calculators and formula are built on the platform. I mean, this makes life so much easier, reduces errors, and gives us, again, one-stop measurements and one-stop calculations and one-stop printouts. So I can't tell you how valuable that is. There's obviously a lot of reasons why having one platform to do everything is helpful, but that alone is a feature for me that I think is very, very useful in terms of all the reasons we talked about. It's pretty evident that we're in the era of new modern generation IOL formula. We've come a long way from the two variable formulas, and I think multivariable formulas are where I see things are currently. My preferred formula at this point in time is the Barrett, like many people out there, even not even for toric lenses, but just for routine IOL calculations of all sizes. There's no axial lift adjustment needed for long eyes. It's effective in shorter eyes as well. So we find the broadest range of application with the Barrett. The Barrett toric calculator, I think, has become the predominant calculator for toric IOLs because, of course, the compensation for posterior cornea and the adjustment of ELP in the toric calculation. So having the Barrett on the platform again and it being our favorite formula to use again is another value. It's something we do even on other platforms. When we don't have the Barrett, we actually manually enter numbers into the Barrett formula to get that calculation. Well, I think, as far as the Aladdin is concerned, we look at it from different perspectives. From a surgeon perspective, getting us as much data as we can, again, not just on the axial length, but on the cornea. We moved from the importance of axial length, which we know is important, but these optical biometers are very good. We've had a lot of experience with the Aladdin. We find the Aladdin measurements to be very consistent. For example, with side-by-side comparison to the IOL Master as well. But the shift has been more toward the cornea. It's been looking at accurate keratometry, looking at corneal topography, as we mentioned earlier. So that's really, I think, where a lot of the action is as far as the variables are concerned, and some of the errors that can happen. The ability to, again, to have everything on one platform, a one-stop shop, point and click, basically for our technicians as well, is again a very attractive workflow solution. I see, again, we continue to work on combining features from different platforms onto one platform with different technologies, including, of course, the Aladdin. And it's an attractive thing for a practice to have, again, a very form-function unit like this that can allow us to do, I think, the ultimate IOL calculations with the latest software, and everything done very automated. So it's been a very good experience for us, and I think this is the trend we're seeing with these different platforms. We've had experience with a variety of different optobiometers from a variety of different companies. I think optobiometers come a long way. They're all, I think, have a lot of benefits compared to, for example, ultrasound A-scan. We have found our measurements to be consistent. We did a large series of patients where we compared, for example, the Aladdin to the Aladdin Master 700. We found that the measurements were very consistent. The ability to get through cataracts were quite similar. And so we feel confident that we're able to get good axial length. Keratometry, again, quite accurate, and the benefit of having topography on top of it, again, gives us added confidence, for example, for looking at the axis, looking at the magnitude of keratometry for toric lenses. I'm one, for example, typically liking to use my magnitude and my actual absolute numbers on keratometry and look at the axis on topography combined together to allow me to give me the best position for the lens and the best toric IOL to apply to, using, again, the latest Barrett generation formula. So, for me, it's kind of an all-in-one. It does everything that I need it to do as far as a machine, as far as ability to calculate IOLs, not only for premium lenses, quite frankly, but for all patients who are going to cataract surgery.